Are we online with you? Are you there? Hello?
Yes, sir.
Oh, great, great. Let us I put the camera in some other position. Just a few minutes ago, I've got the connection, electricity and connection. Before this, we didn't have any at all. I am so happy about this. Just a moment. Let me change the position of the camera. Okay. Here we are. Good. So glad to see you. How many students do we expect today? I see 5 of you, right? Any more? Okay, I'll
We don't know actually how many.
pardon?
No, sir, we don't know how many students will come.
Oh, I see. Thank you for your response. I have sent the reminder to the students, and let me remind you also not to forget to register today. Copy, let me see. Don't forget to register today. Oh yeah, someone has already registered. Kamalevo Karabo. Nice, good. Okay, tell me please, what questions in occupational diseases have you got already? We have already with you discussed the topic of introduction and dust pathology. Any more ideas, any more questions? Have you already started learning or studying this subject? Hello?
No, sir.
No? Okay, okay. So, as I have introduced already, today we are going to discuss intoxications. Let me find the presentation. Just a moment. Okay. We'll start from general aspects of intoxications, of course, occupational intoxications, with the predominant affection of blood with you. While we have also the some reserved topic, emergency in occupational diseases, and as soon as one of often emergent conditions is intoxication, it will correlate, it will be connected with our today's main topic. Again, don't forget to register for the lecture, okay? Let me, maybe I see that only one of you have registered, so let me copy and paste this link to you. Oh, and I have to make one more procedure. One moment. Good. So let me share the screen, entire screen, and presentation. Okay. Do you see the presentation now? Let me check. Let me control. It's so nice when we have connection. Oh my God, just a moment again. Join. Do you see the presentation now?
Yes, sir.
Great. Oops. Turn off audio. Okay. By this, I will control whether you can see the presentation. So as you can see, our today's genuine topic is intoxications with predominant affection of blood system. Okay. And S. Let me check if this worked. Just one moment. Okay. Yeah, we have the screenshot. No, not. Just again. Oops. I had to. Okay. So it's okay now. Intoxication with predominant affection of blood system. The variety of intoxications which may occur in the clinics, in the practice of occupational diseases, it includes many, maybe thousands of possible poisonings with different substances, almost without exceptions. Almost any, not any, but almost any substance may cause intoxication, more or less, maybe with the exception of pure water and some other exclusions or exceptions. As from organizational point of view, they could be acute intoxications and chronic, and poisoning with one and the same substance in case of acute poisoning and a chronic one may differ significantly. And I hope today I will show you these peculiarities. Oh, maybe I'll describe in brief even now, while you can see this slide. For example, in case of poisoning with aromatic hydrocarbons, on this slide they are represented as benzol. In case of acute poisoning, mostly affection of nervous system dominates, right? It's mostly like narcotic action and maybe even up to sudden death, immediate, very quick. And in case of chronic, prograded, delayed in months and years, and 10 years and dozens of years and so on, benzol mostly, or the group of aromatic hydrocarbons, mostly influence on blood system, on hemopoietic cells. They also cause carcinogenic effect. They indirectly may also, this poisoning may also result in sensibilization and allergic response, and multiple other effects. And only secondary, as at some background, we also expect affection of the nervous system, not specifically, mostly. For example, carbon monoxide, poisoning with carbon monoxide. In case of acute poisoning, there is a expressed bright clinical manifestation characterized by hematic asphyxia with appropriate change of skin color and increased concentration of this substance in the blood. And this condition may be diagnosed clearly and quickly and efficiently. While in case of chronic progradiate development, influence of carbon monoxide have so smashed, so indirect, so not so concrete or specific results or changes in the organism that we cannot clearly distinguish them from similar caused by other reasons, other causes. And we base our decision of chronic intoxication with carbon monoxide mostly on the basis of some general information. I mean, professional data, working conditions, sanitary hygienic characteristics, the course of these changes, the difference in health states of this person, at the time of employment and further, and so on, indirectly, not so specifically. Okay, let's continue. The general classification of intoxications with a predominant affection of blood has 4 pathogenic groups and 5 main clinical laboratory forms. Let's discuss. There is a group of occupational poisonings associated with direct influence on bone marrow. On this slide, they are represented as caused by affection of bone marrow. This type of intoxication is typical for poisoning with aromatic hydrocarbons, benzol, toluol, xylol, and others, hard metals, and for instance, if we widen our understanding of the matter, not only in case of intoxications, this mechanism is also a feature of radiation sickness, radiation disease. And main laboratory changes and appropriate clinical manifestation is, or they are connected with hypo and aplastic conditions from side of blood, from side of other systems and organs, but now we're speaking specifically about blood, as well as general affection of the organism. So we name, that is why we name this group of intoxications not specifically blood poisonings, right? But there are intoxications with predominant affection of blood. This means that many systems are affected, almost all of them, but predominantly blood system. Second pathogenic group associated with blood affection caused by toxins is associated with affection of already circulating hemoglobin. There are 2 main branches of these variants of this group, like med hemoglobin associated poisonings and carboxyhemoglobin formation associated intoxications. Methemoglobinemia is a feature of acute and chronic affection or poisoning with amine and nitric compounds of aromatic hydrocarbons. And carboxyhemoglobinemia is a feature of carbon monoxide poisoning. The third group, pathogenic group of occupational intoxications with predominant affection of blood is related to hemolysis of already, again, circulating blood. It's a feature of intoxication with arsenic compounds, and more or less expressed hemolysis might be also present in case of acute and very severe poisoning with amine and nitric compounds of benzol, aromatic hydrocarbons. In this case, on laboratory or clinical level or aspects, we are faced with signs of toxic hemolytic anemia. And the final 4th group, pathogenic group of intoxications with predominant affection of blood, is associated again with problems with production of hemoglobin, blockage of hemoglobin synthesis. Today we'll discuss this group on the example of lead poisoning, mostly chronic lead poisoning. This condition is on laboratory pathogenical level connected with so-called siderocrestic anemia. This means that there is a problem of use of application of iron in the production of hem as a component of hemoglobin. So let's move forward. Occupational intoxication with lead, you may see this condition is coded as T56 by International Classification of Diseases. and also known by the terms Saturnism or Plambism. These two terms come from Saturn, such a planet, yeah, with a grayish color on the telescope, and association of this discoloration of this color with discoloration of the skin of persons with depositions of lead in skin as well, and with anemic condition and so on. And Plambism directly comes from the Latin term, Latin name of the chemical element, lead, plumbum, right? So this condition may be defined as occupational disease resulting from, it's important, I especially emphasize this with greenish color on the slide, prolonged contact with lead in concentrations that exceed maximum permissible values, maximum permissible concentrations, and characterized by predominant disturbances of porphyrin metabolism in combination with affection of nervous system. Again, what is important? Occupational, prolonged contact with lead in exceeding maximum permissible concentrations, and predominant affection of porphyrin metabolism and nervous system. This is minimum I'd like you to remember in this topic. And on this slide, I just describe this association, etymology of this term. Saturnism as intoxication with lead with Saturn, with the name of planet, because of such a discoloration. The chemical element, the causative agent of this intoxication, lead, or in Latin plumbum, has unique technological properties, because of which lead have been or has been used in different applications for maybe several thousands years. Just imagine, thousands years. For example, because of its softness, it may be easily modeled according to the needs of the humans. Like there could be some pots made from lead, some pipes, and many other things. Due to its elasticity, it is also easy to modulate it, so to model it according to the needs. Ductility, I mean electroductility, helps, makes possible to use it in electricity conduction, in electronics even, and it's even nowadays is widely used in batteries and in other applications. Low melting point, it's extremely useful because I'm not sure whether you have did this, but when I was young and when I was child, I just put a piece of lead into spoon, and by using a simple open fire, I melted it and made anything I want from it. Some tanks, some soldiers, some other figures, animals, and so on. Many things may be done easily just in at home. And then next property as steadiness to alkali and organic acids make it possible to use it in chemistry sphere, mostly in ancient, of course. Nowadays, not so, we have much more modern materials for this, and ability to get dissolved in all metals except iron is widely used in foundry departments, in foundry in general, in metallurgical departments, in mansion building ones, and so on, to achieve very high temperatures and pressures, and in these conditions to get some extra extra sorts, probably sorts of alloys, metallic alloys. Okay, and the toxicity of this element is the following. The maximum permissible concentration is 0.01 milligrams per cubic meter. So in few words, it's rather toxic, right? Comparing with, for example, what we have studied last lecture, we had the MPC of, for example, coal dust and silicon dioxide dust containing dust, about 1 to 6 to 8 milligrams per cubic meter. In this case, it's much more toxic, but it is in turn much less toxic than we have studied with you again last lecture, beryllium. As far as I remember, beryllium is 100 times more toxic than lead. The lethal dosage of lead for human being, depending, of course, of the condition of the organism, on the weight, age, and so on. So the lethal dose varies from about 300 milligrams per cubic meter, I mean the concentration of dose, but concentration in the air of open area, and up to about 800 milligrams per cubic meter. The lethal dose already observed varies from 150 to 450 milligrams per kilogram of weight of the person. So it's moderate toxicity, I must say. The occupations in which there is a relatively higher risk of occupational intoxication with lead include the following group of professions. Of course, there are some more a part of these, but in brief, here they are, such as battery makers, such as, for example, pottery workers, right? Like even solderers, welders, jewelers, and others. The exposure to lead might take place in different conditions, in different associations, industrial associations, or industrial locations. It starts at the place of mining of lead. Here is the example of these quarries where lead is mined. And on this slide, I try to represent the samples of different lead-containing ores. As you can see, some of them are colorful, some of them are just black or white, and lead is we get lead from them. The next stage, industrial stage of production, manufacturing stage, in which there is also a high risk of contact with lead and intoxication with it, is probably refinery factory, where all these ores is enriched and processed and further melted into final formats, right? Final these foundry pieces. You may see the chambers, industrial chambers, in which they process lead. And on the bottom of this slide, I represented just non-industrial, at-home episodes or examples of exposure to lead when they melt the lead just at home. So potentially there is a risk of lead poisoning not only in occupational conditions but also in general conditions at home as well. The exposure might be also present in warehouses, in process of transportation of these pieces of lead, as you can see. One more example. And in further application of lead in different productions, right? Manufacturers, like production of batteries, production of wear shields. And there is one more exotic nowadays sphere in which they also has been a very high risk of the influence of lead. There are typesetters and other people related to typography. In past times, they have been using types made from lead, and therefore they have been exposed to lead. And as soon as lead has inclination to get absorbed and accumulated in the organism, there is a risk of delayed effects from it on the organism. The main entrance ways of lead into the organism are respiration, gastrointestinal tract, and very small portion might be directly transferred through the skin. The biological effects are various, and predominantly they are present from side of blood system, nervous system, gastrointestinal tract, cardiovascular system, and others. We will discuss them today thoroughly. After entering the organism and conducting its biological effects, some portion of lead is eliminated, but some of it remains in the organism for prolonged time, for some different time. The depositions are subdivided into exchangeable fraction, it's about 10%, and more stable, it's about 90%. So as you can see, lead has an inclination to get absorbed and deposited in the organism for rather prolonged time. And part of it is continuously eliminated from the organism. So even after stoppage of work, after discharge from the place of work, some residual changes of lead remain in the organism and get eliminated with urine, with feces, with any other excretions, with sweat, with milk during the lactation, and so on. Let me have a look on us. Good. Oh, dear students, there is no reason to put your names in the chat because no one will control this. I have sent you the link by which I'd like you to get registered to the lecture in your invitation to this meeting. Then I have repeated just at the beginning of this lecture in one more email, and I also copy and paste this link to the feedback form in your chat now here. Please follow it and get registered in Google form. And let's return to our lecture. The depositions are heterogenic. Some part of lead is remaining in circulating liquids in the organism, and the half-life of this portion of this fraction is weeks, several weeks. This means that in approximately 1 or several months there is a chance to get all the lead eliminated from the circulating liquids. fluids. Unfortunately, the process of deposition of lead in the organism is not so staged, and it is simultaneous. So already at the time when some portion is circulating in the blood, some part of it is deposited in parenchymatous organs, and half-life of this fraction of this portion is months. So this means that we may expect that in a few months or year or two, we have a chance to get eliminated all the lead from parenchymatous organs. By parenchymatous organs, I understand brain, lungs, spleen, liver, muscles, and so on. And here, from biological liquids and parenchymatous organs, we have many ways to get excreted with urine, with bile, sweat, and hair, and nails, and so on. So lead is present in everything. And unfortunately, again, as soon as this process of making depositions is simultaneous, some part of lead is deposited in bones, and this is the most stable fraction, the most stable portion of it. And in bones, the half-life of presence of lead is years. There were even some cases described when workers from battery assembling manufacturers demonstrate, they show the presence of this lead in 20 and even 30 years after stoppage of work at all. This means that this portion of lead may remain forever during all the life of this person. And of course, these portions are interchangeable. And we use this widely because while using special efforts, special measures to decrease concentration in circulating blood, circulating liquids, we increase the backward pass of lead from parenchymatous organs in liquids, and we in turn have chance to excrete it. And simultaneously, some portion, very small one, but anyway, we can do it. Some small portion of lead comes from bones into liquids, into parenchymatous organs and back. So these parts, these portions are interchangeable, and we use it in our evaluation of the cases of lead poisoning and our efforts in treatment of this condition. Now let us discuss the main biological effects of lead on the organism. Basically, lead realizes its action in two main mechanisms. Affection of enzymes, more specifically sulfhydryl groups of enzymes, and entry into cellular metabolism by the competition with or antagonism with the calcium principle. Let me see and just have a look. Anyway, you continue. Please, Mahmoud Al-Maksus, please register following the link. There is no reason to put your name in the chat. No one will control this, okay? Just follow the link. It's present in your emails and what else? In emails and invitation to today's meeting as well, and so on. Okay. Just again. Okay. And let's return to the presentation. Good. Finally, the resulting effects from these influences are associated with hematological toxicity, influence on blood, influence on nervous system, gastrointestinal tract, liver, kidneys, cardiovascular system, endocrine, reproductive, immune, and all the other systems of organs with predominant affection of two of them, blood and nervous system. The rest are either not so specifically affected, or they are not so strictly, right, not so severely affected. The pathogenesis of influence of lead on the blood system, from one of points of view, one of approaches, is related to the is related to the affection of porphyrinic metabolism, more specifically synthesis of heme. As you can see, there are two places on which lead is influencing on enzymatic systems. It affects a group of enzymes of dehydratase delta aminolevulinic acid, and on heme synthetase, it's also named ferrochelatase. This results in blockage of appropriate stages of synthesis of heme, and finally, this leads to such laboratory and partly clinical manifestations as increase of concentration of delta aminolevulinic acid in blood and in urine, and you may measure it. Its increase of iron in blood and depositions of it in muscles and liver, and leads to decrease of heme or hemoglobin. And this condition is named sideroacrestic anemia, decrease of hemoglobin on the background of increase of iron. And of course, it has more or less expressed clinical manifestations. Non-specific anemic syndrome, plus other signs of lead poisoning from side of nervous system, from side of skin, gastrointestinal tract, and other systems and organs like cardiovascular and so on. Other aspects of blood affection is related to development of hypoxemia and hypoxia of tissues, which results from anemic condition. This leads to reasonable, like reciprocal activation of erythropoiesis, and we may observe increase of count of reticulocytes and cells with basophilic stippling. In other words, in mature forms of hemopoietic cells, of blood cells, of erythrocytes in this case. One more aspect of pathogenesis of blood affection is related to the fact that as soon as lead also influences the erythropoiesis, production of red blood cells, this results in structural and functional changes of red blood cells, and in turn leads to decrease of red blood cells life and elevation of young immature forms of red blood cells in blood, reticulocytes and cells with basophilic stippling, as well as bilirubinemia and bilirubinuria as a result of often and more expressed destruction of red blood cells. One more aspect of blood affection is more related to immune system, because lead influences on all the enzymatic systems, including those which conduct protective function in immune cells, in immunocytes, and this leads to changes, to deviations in immune reactions in form of different immunological disturbances, like predisposition, non-specific predisposition to infections, and even up to autoimmune pathology. One of aspects of this predisposition is so that as soon as lead influences on enzymes of immunocytes of non-specific immunity, compensatory, the specific part of immunity dominates, and in this effort to compensate the immune function, it realizes more expressed sensitization to the external and internal antigens and possible immune, allergic, or autoimmune hyper reactivity, immunological hyperreactivity, or autoimmune pathology, finally. Other aspects of influence of lead on the human organism in the process of occupational intoxication with lead concerns influence on nervous system. This may result in affection of, again, enzymes in nervous system, and therefore disturbances in generation of nervous impulse and its conduction, and direct toxic influence of neurons with competition with calcium. This finally results of both of these changes, both generation of impulses affected and conduction. Pardon? One moment. Oh, dear students, there is a time comes when there could be sudden and unexpected switching off the electricity and internet connection. In this case, just wait for a while. I'll join you in a few minutes from my mobile phone and I'll continue the lecture, okay?
Yes, teacher.
At the moment we have everything, but in any second it may happen. So and on the clinical level, there is manifestation from side of somatic nervous system and in general higher functions of nervous system with psychological and even psychiatric syndromes development. We'll discuss what exactly. From side of cardiovascular system, and one more, now it's formally coming the time when I have to do to make a break, right? But as soon as any time there could be a break caused by this accident, I propose you to continue the lecture and maybe finish 10 minutes earlier. Do you agree with this? Can we continue without the break?
Okay, sir.
Okay?
Yes, sir.
Thank you. Let me again make a screenshot. I was asked by your dean office. Okay. So again, same mechanism as you can see. Affection of enzymes results in changes in vascular layer of vessels. Affection direct affection of myocardium, and changes even in endocrine regulation of vascular tone and cardiac output and everything. As an example, affection of renin, angiotensin, aldosterone system. A part of this, of course, a significant influence on all the tissues, all the systems, including cardiovascular one, is conducted by anemia and hypoxemia. And same, the direct toxic influence on endothelium remains by the same mechanism of antagonistic competition with calcium and change of metabolism of endothelium and development of endothelial dysfunction, and therefore predisposition to atherosclerosis, to arterial hypertension, to myocardial dystrophy. And these changes have their clinical manifestations in turn. The affection of gastrointestinal tract may be also described in the following several mechanisms, like vegetative dysregulation and affection of secretion and motor function of GAT, formation of immune complexes. If you remember, we have already discussed this in the parts of blood affection and immune changes and inclination to specific immunity and autoimmune processes and so on. So these immune complexes might also circulate in the blood and affect the microcirculation in the capillaries and tissues. And direct toxic influence on cells remains as well, always. This results in the phases of a hyper secretion, intensification of it, and then phase of hypo, exhaust of secretory function of gastrointestinal tract, and hypoacidic condition and hyposecretion in intestine and so on. And decrease of motor function as well, and these may be manifested in the form of stable, prolonged constipations without any significant relief from purgatives and so on, and so on. And development of pain, it's because of ischemization. These changes of macula circulation, as well as hyperactivation of vegetative ganglia, results in spastic condition of bowel, of intestine, and it's painful. We'll describe, it's even named lead colic, such a syndrome of lead colic. The pathogenesis of these changes is referred to disturbances of microcirculation in the liver, right? Affection of liver enzymes and general influence of anemia and hypoxemia. And in turn, this leads to functional and morphological structural changes like disturbances of function, liver function, and inflammatory changes. And we describe these conditions in two terms. They could be hepatopathy, as some not so prolonged, not so morphologically or structurally developed, expressed condition, and then transformation into hepatitis. The feature of this toxic hepatitis is so that it almost never transforms into cirrhosis. It has a relatively beneficiary course, of course, in case if we help this patient, right? If we treat him correctly. The mechanism of influence on urological sphere, on kidneys in this case, is related to following three aspects, like dysfunction of tubular epithelium and development of tubulopathy. It's some just transitory condition with some minor changes, and maybe possibly the transformation into tubular interstitial nephritis with dystrophic changes in tubular epithelium and fibrotic changes and so on. And there is also a risk of metaplasia of tubular epithelium, and development of adenocarcinoma, the tumor, right? From side of endocrine system, lead influences also systemically on all the endocrine glands, with some examples on this slide. It influences on adrenal glands, on hypothalamus and hypophysis, on pancreas, with primary stimulation of them, and therefore appearance of appropriate clinical manifestation, and then by ex-host hypofunction, decrease of the function. The reproduction system is also affected more or less. In men, it's affection of spermatogenesis. In women, ovary function, and they could be also direct influence on fetus in females. It also may be conditioned, or these changes may be conditioned by endocrine disorders, etc. And this results in some grade of infertility or pathological pregnancy. Even teratogenic effect may take place. So, from this point of view of influence on reproduction function, there is a high risk for fetus, for child, in case if his mom, this female, has underwent the influence of lead many years before the pregnancy. And we should take care about this and thoroughly define and thoroughly revise the history, the anamnesis of every such case, especially in women, whether she has been underwent or has been in contact with lead previously, and should conduct appropriate investigation and then make a decision about the pregnancy and delivery and everything. Let's discuss the clinical manifestation. As opposite to the fact that we have discussed with you that most specific changes in case of chronic poisoning with lead take place from side of blood system, on clinical level, these changes in blood system remain not so significant, not so detected until they become severe enough. And therefore, mostly changes from side of nervous system dominate on the early stages of development of intoxication. Here is the one of terms, neurosaturnism. We remember probably that saturnism is a term for intoxication with lead. Neurosaturnism is used sometimes when we need to describe that this person has neurological manifestations of intoxication with lead. Neurological changes start from non-specific, asthenic, vegetative symptoms like complaints on sleep disturbances, general weakness, irritability, changes of memory, some amnesia, transient pains and extremities and joints due to depositions of lead in them, and some maybe secondary also inflammations, etc. Some non-specific headache, depression, loss of libido, and impotence, gastrointestinal disturbances. So some plenty of non-specific complaints which may occur in the wide spectrum of different conditions, different diseases, not specifically in lead. In other words, there are no specific, not even typical, there could be no typical clinical manifestation of lead poisoning at this stage. Maybe with only one exception, lead line and discoloration of the skin. I'll show you just in few seconds or minutes. Objectively, we may detect emotional lability, vegetative dystony. Sometimes they could be more expressed tendon, how do they name it? Reflex, right? Reflexes. Here is the only one of examples of not specific but typical clinical manifestations on this stage, and even pre-disease, even when there is a carriage of lead, there is not a disease even, just carriage. These persons may represent such a discolorations of their gums edges. They become, they get some bluish or greenish tinge. This develops because of depositions of salts of lead on the mucous membrane of oral cavity, sometimes on teeth as well. And this symptom is not stable. So it may be present even in persons without disease, but only carriage of lead, and vice versa. Even in severe lead poisoning, this symptom may be absent. It depends on many aspects, most significantly maybe from the level of oral hygiene in this patient, in this person. If he conducts it properly, he simply washes it out, cleans the teeth and so on, and no such symptom may be present at all, especially in chronic poisoning. On the next stage of progression of chronic poisoning with lead, we expect the development of so-called peripheral polyneuropathy or polyneuritis. On this stage, complaints a parts of, so in addition to previously present and their growing, also complaints on paresthesia, decrease of severity, sensitivity, and with further progression into motor disorders and decrease of stamina, and then even strength, and even development of paresis. So the symptoms of dropped hand and dropped leg might develop, might be present in these patients at this stage. Here is the illustration of this condition, like a scheme, right? So sometimes they demonstrate the symptom of paralysis. At the most advanced stage of neurosaturnism, they could be even more expressed disturbances from side of central nervous system, on the background again of growing and increasing all previous symptoms. They could be stable headache, diencephalic crisis, and this diencephalic crisis in turn may be manifested by different clinical masks like hypertension or hypotension. They could be cardialgic and cardiac arrhythmic. They could be gastroenterological and epileptiformic masks, like patterns of this diencephalic crisis. So they could be different manifestations, and doctors should be again aware about the possibility that all these may be caused by chronic poisoning with lead. And objectively, yeah, you may register disturbances of speech, coordination, movements, right, reflections from cranial nerves, even symptom of lead meningitis, and so on. On this stage of encephalopathy, rather often these patients also represent the symptom or syndrome of lead colic. I'll describe it on some next slides and we'll discuss with you. The diagnosis is conducted on the base of evaluation of clinical manifestation and, of course, obligatory additional investigations. And, for example, from side of blood system, making the laboratory test, complete blood counts in this case, help us to reveal reticulocytosis, increase of basophilic granularity of erythrocytes, and anemia. From side of gastrointestinal tract, the diagnostic criteria include gastric hypersecretion with further hyposecretion, development of so-called lead line, discoloration of gums edges, increased salivation, decrease of pancreatic function, development of syndrome of lead colic with pain, constipations, and rise of blood pressure. These three components are features of this condition. So if lead colic is present, we may state that this is advanced stage of chronic intoxication with lead, with chronic spastic colitis and possibly toxic hepatitis. Let's focus and discuss more thoroughly this syndrome of lead colic. Typically, lead colic develops on the background of some precipitating agents, precipitating factors, some conditions, like they could be preceding physical overload or straining, or mental stress, or excess maybe use of alcohol, drinking of alcohol, or maybe again excess eating of spicy or fatty food, and so on. What's the mechanism of this? As soon as maybe you remember, lead is deposited in liquids, in parenchymatous organs, and in bones, the concentration of lead in liquids, in blood, for example, in circulating blood, varies significantly because it is continuously eliminated from it. But in some conditions, when parenchymatous organs undergo overstraining, functional involvement, some excessive involvement, for example, physical training or physical overload leads to intensification of metabolic processes in muscles, or mental stress, same for brain, or for example, in case of excess drinking of alcohol, it's metabolic intensification of metabolism of pancreas and liver and muscles and even nervous system as well. So all these conditions mobilize, so they are they predispose, they make such predisposition to increase of concentration in circulating blood, because it comes from parenchymatous organs. And in this condition of sudden increase of concentration of lead is manifested by sudden development of lead colic. By sudden, I understand not so acute, but so it's severe. It could be very severe pain, but it develops gradually. But so it may take from several hours for development of this lead colic to, just imagine, several weeks, very gradually. And we should review these aspects in questioning of the interviewing of the patient, and making diagnostic ideas about what can cause this pain. And unfortunately, in this condition, periodically, and I must say rather often, doctors get mistaken because they confuse this condition with, for example, acute abdomen condition, and in turn it may be associated with inflammatory changes in pancreas, in liver, in different locations of different organs, and this constipation which is present maybe also is confused with bowel disturbances, surgical condition, and unfortunately in this case they proceed with their surgical approach, and this significantly worsens the condition of the patient. Of course, this is mistake, and in this case, if there is such a pain in paraumbilical region and associated with rise of blood pressure and constipation, and of course, if it is possible, you get the information that this person previously, maybe years, dozens of years ago, had contact with lead, or even if you don't have such information, but you may guess, for example, you observe this lead line discoloration, and you conduct the complete blood count and reveal some excess amount of reticulocytes and this maybe even red blood cells with basophilic stippling and anemia. Anemia may be, of course, caused by hemorrhage, but once again, if there is no hemorrhage but presence of anemia, you should think about possibly intoxication, chronic intoxication. And in this case, there is even an express test possible when very easily in just few, if not seconds, but minutes, you may detect either directly lead, it's more expensive, but more cheap is to detect the metabolite of porphyritic metabolism, delta aminolevinic acid. If you remember, we have discussed this with you when discussing mechanisms or pathogenesis of lead poisoning from side of blood system. There was a blockage of heme synthetase and accumulation of delta aminolevinic acid. It's a feature. It's non-specific only for lead poisoning, because this may happen also by different reasons, even congenital, some genetic reasons. But it's one of possible ways to suppose the correct diagnosis and avoid wrong procedures, wrong operation, surgical operation. Because otherwise you might think that this is some purulent, some inflammatory change, and proceed with the operation. This may kill the patient. In the course and development of lead poisoning, chronic lead poisoning, we distinguish several stages or forms. First stage or initial form. Usually it is clinically asymptomatic at all, while on laboratory investigation we may detect reticulocytosis up to 25 per mile, elevation of basophilic stippling of erythrocytes or basophilic stippled red blood cells up to 40 per miles, and elevation of concentration of lead and delta aminolevulinic acid and porphyrins in blood and in urine, for instance. You may detect it easily even in urine. On second stage of chronic poisoning with lead, moderate form, clinically we may detect so-called asthenovegetative syndrome. We have discussed with general fatigue and so on, sleep disorders, initial forms of peripheral polyneuropathy with motor dyskinesia, with violations of liver function and so on, reticulocytosis from 25 to 40 per miles, elevation of basophilic granular erythrocytes or red blood cells from 40 to 60 per miles, development of anemia, and elevation of lead and delta aminolevulinic acid and porphyrins and even iron in blood, mostly. It's most easily, and lead and delta aminolevulinic acid and porphyrins in urine as well. And on third stage, severe form of chronic poisoning with lead, we observe lead colic. We have discussed with you what is it. Asthenovegetative syndrome, even more expressed than previously. Polyneuropathy by sensory, vegetative, and motor types, encephalopathy with, if you remember, diencephalic syndrome and so on, toxic hepatitis with appropriate dysfunction, liver dysfunction, and so on, anemia from side of laboratory tests, reticulocytosis exceeding 40 promils, and elevation of the count of basophilic stippled red blood cells over 60 promils. And of course, again, elevation of lead, delta-malonic acid, porphyrins, and iron. For instance, the concentration, the absolute level of concentration of lead, delta-malonic acid, porphyrins, and even iron rather often does not correlate with the quantity of deposited lead, because significant part of lead is deposited in bones, and this portion is metabolically inactive, but it may come into bloodstream anytime under the change of metabolism after overstressing, overstraining, and so on. So the principles of diagnosis of chronic poisoning with lead is based on medical and occupational history of exposure to lead in concentrations exceeding maximum permissible, and usually it is history of prolonged exposure, like 10 years and more, while sometimes even shorter period may result in carriage of lead or even development of intoxication. On physical examination, you may detect some typical symptoms like discoloration of gums edges, we name it lead line, and general discoloration of skin of grayish type. And all the rest of clinical manifestations are non-specific. There are changes of reflexes, the paleness due to anemia, there are symptoms of liver dysfunction, there are symptoms of nervous system dysfunction in such a irritability and polyneuropathy by sensory vegetative, and motor types, and even encephalopathy with disturbances of cranial nerves function and diencephalic syndrome and so on. Then, blood pressure measurements help us to reveal indirectly, of course, the affection of for one hand vegetative nervous system, for other cardiovascular system. And for instance, I forgot to emphasize this in the parts of pathogenesis, pathophysiology of cardiovascular system. For instance, in these patients, in these persons with lead poisoning or even just carriage of lead, rather often we observe such a problem as significant predisposition to atherosclerosis and arterial hypertension. The reason of atherosclerosis is mostly related, by our hypothesis, to endothelial dysfunction and progression of all this, and in turn arterial hypertension correlates with severity of atherosclerosis from one hand, and from other with this hyper irritation of sympathetic part of nervous system and inclination to vasospastic condition, right? So it leads to increase of blood pressure. And one more idea I'd like to share with you is so that from my experience on, and in general from the literature, rather often clinical forms of atherosclerosis develop in these patients at their relatively early age. So at the age of 35, 40, 45, sometimes I have patients with several episodes of either myocardial infarction or ischemic stroke or some similar conditions related to atherosclerosis and arterial hypertension. So it's you should be aware about this possible reason of atherosclerosis as well. There is even a special theory of xenobiotics developed in relation to atherosclerosis. Okay, so blood testing help us to reveal the lead concentration increase in blood, changes in complete blood count include what? Anemia, increase of reticulocytes, red blood cells with basophilic stippling. These are main. Then serum iron is increased, serum creatinine is increased, protoporphyrin is also changed. And urinalysis. In general urinalysis, we may detect changes of kidneys, of urinary tract in general, and elimination of delta amyloidic acid and lead and porphyrins as well. And other tests, if clinically indicated, may be also performed, such as, for example, electroencephalography, so polysomnography, and so on, many other approaches. The treatment of chronic poisoning with lead is partly specific. It's not specific, but it's has some features, right? As soon as lead is metal, it's heavy metal, we use chelating or complexing agents, complex zones, so-called complex zones, such as stethosine calcium, pentacene, or the D-penicillamine, and so on. We may use them perorally or in injections, or more often in systems, right? Intravenously. And there is a specific regimen of use of these complexing agents. We name it staged or alternate scheme. What do we understand by this? We start the treatment, depending on the severity, of course, of it. There could be stages of 3 to 7 and even sometimes to 10 days. When we use for 3 days, then 3 days of pause, then again use and then pause. And we make 3 cycles of these courses per one approach, and we conduct about 2 to 3, it depends again on the severity, up to 3 approaches. I mean the courses, 3 courses of this eliminating or therapy for these patients per year. Why it's conducted not permanently, and why it is staged scheme? The fact is that when we have the patient that first time, rather often he demonstrates relatively high concentrations of lead in blood, and we conduct the elimination of lead significantly and efficiently during first few days. But starting from approximately 3rd or 5th or 7th day, the efficacy, the shift, right, the decrease of concentration of lead in blood becomes not so big from day to day. And vice versa, the risk of side effects of complexing agents, of these chelating agents, increase because of prolonged use of them. These side effects might include affection of kidneys, liver, nervous system in turn by themselves. That's why we stop using them, wait until some quantity of lead will come into the circulation, into the blood from parenchymatous organs, from bones, and so on. We do not measure it, but we just suppose that it increases. And then repeat this elimination therapy again, and then repeat all these cycles several times. Previously, we even have been using special provoking tests for this. We, for example, administer either physical load for them or some metabolic intensification or so. Now we don't, because of danger of lead colic and side effect of such approach. We simply wait. This patient conducts his usual lifestyle, and anyway, we observe increase of lead and then continue with elimination of it. So this staged or alternative scheme is useful in treating of lead poisoning with chelating or complexing agents. Apart of this, we use neurotropic treatment in case of neurosaturnism or preventing it, like B complex, ascorbic acid, spasmolytics, ganglion blockers in case especially of lead colic developments. Physiotherapeutic methods also help significantly. As soon as we observe anemia, we use iron, not wrong, but iron preparations. There is a misprint there. Hemostimulin, vitamin therapy with B complex again, and symptomatic or on-demand therapy depending on what exactly happens with the person, with his organism. The expertise of ability to work ability, is the following. At initial form of chronic poisoning with lead, occupational poisoning with lead, during 1 to 2 months, we conduct the treatment, rehabilitation, and eliminate this person from work. And if his condition restores fully, he may continue to work, but strictly in favorable conditions. What does this mean? This means that if at his previous place of work they were exposed to these toxic substances, to mental overload, to physical overload, to overstraining, and so on, use of other toxins, a part of lead, we change his place to other, or if it is possible to continue to work in same place because conditions become favorable. For example, there is automatization of this production, even robotization and so on. He may continue. At moderate form, we continuously, constantly eliminate this person from contact with toxic substances. On severe form, unfortunately, it's almost always a constant loss of ability to work, invalidity group, and he should not work in any contact with any occupational hazards. Let me check the time. So the next intoxication, which I'd like you to emphasize on, is occupational intoxication with benzol. As soon as, if you don't mind, it's time to finish the lecture, I will send you this the link to. Okay, I see your request for attendance link. Please, here it is. It's also present in your emails. So I'd like to finish the lecture at this. Oh, sorry. At this stage, and we'll continue with you in 2 weeks with next lecture. If you have any questions, let me see. No questions. Okay. At the moment, there are no questions, at least in your response, but maybe you have got any and you may ask them orally. Do you have any questions in relation to occupational intoxications or any other aspects related to occupational diseases at the moment?
No, sir.
Please take care in your inbox, I have sent you the invitation to this lecture, and now I will send you the links to my presentations as well. Let me find them. And I introduced different options for you. For example, I record all my lectures and upload it to the YouTube channel. If you have missed any lecture, feel free to to attend, right? To listen to the lecture from the YouTube record. And after postscript, I have invited you into many of my projects, privately or personally. If you are interested in fundraising for medical reasons, medical projects, you're welcome. I have now the next generation of students to teach how to fundraise, right? I also am studying, for instance. And finally, we conduct this fundraising for different reasons, for mostly social projects. The second one is exactly about one of my social projects. It's about medical cluster. And you may see I have introduced, I didn't introduce it for you last time because there was no electricity and internet. In few words, the medical cluster is such a social project in which we combine the efforts of both medical business and non-private medical organizations and non-profit organizations and academic structures like university where you study and I work, and other companies and physical persons related to medicine, and in partnership with local communities on regional, city, village, and other and country levels, and foreign partners, we conduct different programs. These programs will be described by the link available in this presentation. Link to this presentation I have sent to you in your emails after postscript. And here is the description in two languages, in Ukrainian and in English. So you may focus on English version. We have several programs for children, for military people, wounded military people, and for medical personnel. Now we conduct MVP, minimum viable products, in Ukraine, in Transcarpathian region, more specifically in Uzhhorod, city of Uzhhorod. But after we succeed, we will distribute this experience to other regions of Ukraine and even abroad. So if you are interested in getting related to this experience, you may be here as an expert in medicine, as a volunteer, as an educator, even if you have these skills, as maybe expert or specialist in different fields, or as a student, as a variant. So there are many applications here. As you can see, I even make such a comparative table, what resources we get from what partners and members of this medical cluster. It's my own project. I just I conduct it with all my soul and all my force. So if you are interested, you are welcome. And the very last one, if you are inclined to learn the field of medical researches, medical investigations from side of methodology with, you're also kindly welcome to conduct these procedures with me. I have my own students, even postdoctorate and clients as well. If you already experienced it, we could get partners with you, conduct the partnership. If you want to study, I can share my experience with you, again, in the field of methodology of of uh, methodology of scientific researchers, right? So thank you for coming. If you don't mind, let us finish this lecture. I'm glad to see you again. Let's keep in touch. Don't forget to get registered. Yeah, thank you. You have already in the feedback form. Thank you. Good luck. See you in 2 weeks or earlier if you are interested in any context. And I promised to send you the link to these presentations. Just one moment. I will share with the link to the presentation. If you have any remaining question, it's exactly a right time to ask. Okay, I've sent everything to you. Good. So I'm online. I'm still online. If you have questions, feel free to ask. Now I'll make reports to everywhere. Mm -hmm. Oh, I have to. Good. Let us see.